everyone. I'm happy to be here and come talk about what I think is the fascinating complexity of the vestibular system and why, as otolaryngologists, and otologists specifically, we should be playing a central role in those pathologies. Um, these are my disclosures, and this is the ambitious outline. I don't think I'm going to be able to cover all of that today, but I'll do my best to hit all of those points. And starting with going over the complexity of the peripheral vestibular system, moving on to the rich network that the central vestibular system is a part of, and then talk about the impact that the vestibular system has on the higher executive functions. So for this group, I probably don't need to go into depth in anatomy and physiological review of the peripheral vestibular system, and I will be streamlining this part of the talk to talk about the atypical presentations that we encounter as otologists in clinic and that straddle the line between peripheral and central vestibulopathies. We all know that the inner ear is housed in the petrous apex. We have the semicircular canals and the elliptical and spherical recesses that house the membranous labyrinth containing the semicircular ducts, the utricle, and the saccule. And we know the neurological topography of the vestibular system consists of the superior nerve, vestibular nerve, and the inferior vestibular nerve. And interestingly, the vascularization follows exactly the same dichotomy, with the anterior vestibular artery following the superior nerve and the common cochlear artery following the inferior nerve. This slide from the excellent book of Gulya and Shuknet that shows how intimately close the vestibular system is to the middle ear. And you can see from there that the high drops in Meniere's disease can bring the saccule very close to the middle ear, to the footplate, and hence the known pearl that to avoid doing a stapedectomy on an active Meniere's disease patients is due to that. But when you look at microscopically at the anatomy of the otolytic organs, we also know, all of us, I guess, on this group would know that there is this layer of otoliths that are sitting on an amorphous substance membrane in which the hair cells are embedded. And we also know that the shearing effect of movement can cause a depolarization and a hyperpolarization of the cells, depending on the direction of movement of the stereocilia toward or away from the kinocilium. A similar structure exists in the semicircular canals in the ampulla. And unlike in the semicircular canals, the saccule and utricle are triggered by either a tilting of the head away from the vertical or a translational movement where the utricle and saccule are detecting an acceleration. By convention, the utricle is responsible for detection of the horizontal translation, and the saccule is responsible for detection of vertical translations. And unlike in the ampulla, the same movement in the ampulla always triggers the hair cells in the similar direction, whereas as you see down here in the utricle and saccule macula, the populations of cells can be differentially triggered by the same type of movement. We also all know that the peripheral vestibular system works in a push-pull mechanism. It took me a lot of years to find a GIF that actually illustrates this in a captivating way. And if there is one side that is pulling more than the other, obviously there is either a motion or a perception of motion that is happening. And the entire vestibular physiology is sustained by the three laws of Ewald that stipulate that a stimulation of the semicircular canal causes a movement of the eyes in the plane of the stimulated canal, where the movements of the slow phase of the nystagmus are in the direction of the endolymph movement. And in the horizontal semicircular canal, a flow of endolymph toward the ampulla causes a greater stimulation than a flow of endolymph away from the ampulla. Whereas in the posterior and semicircular canal, the opposite is true. So all of this will allow us in clinic to basically start decoding what's going on with the peripheral vestibular system. To start with the head impulse test, where we ask the patient to fixate on a target, usually your nose, and we thrust the head right or left. And if there's a saccade, if there's a drift of the eye that then corrects itself, then we know there's a weakness in that ear. On this right-hand slide, this is a lady who has a left vestibular schwannoma that was treated with radiation. And you can clearly see when there's a head thrust to the left, there's a complete displacement of the eyes and then recovery with a saccade, whereas the right side is fairly normal. And this is what a video head impulse test would look like in somebody who has an acute injury with a very low gain, which is the speed of the eye movement compared to the speed of the head. And those saccades that we see here completely asynchronous in relation to the head movement, where the brain has not figured out yet what's going on. What is more interesting in that slide is in the acute phases of the injury, you have a low gain on the normal side, that side that is completely intact. And that's part of the central compensation process that happens that we call the cerebellar clamp, where the cerebellum is reducing the impact or the weighting of the information coming from the good side so that the vestibular nuclei don't sense a significant asymmetry. And that's what makes the vertigo starts to subside the first few days after a nerve section or a neuronitis. We also have to remember that in order to function in real life and move and track objects, we have to suppress our vestibular ocular reflex. If we cannot suppress it, we cannot track moving targets. And we also have to remember that the inner ear codes not for a position sense, but more for a speed and velocity sense. And that velocity information that is coming from the utricle, macule, and semicircular canals is stored in the vestibular nuclei where it's integrated into a position sensation. And this way, when people are moving in a fast way, the brain is not decoding things blow by blow or movement by movement. It's storing this information and then releasing it at the end of the sequence of movements, which we see here. If you go to a park and you see those kids, do on the whirl or on the teacups, at the end of this clockwise rotation, when it stops, then basically the brain catches up and the eyes are going to start moving in the direction of the movement of the teacup. And the same thing we will see if somebody has an acute injury on one side after an after head shake maneuver that you have to usually do for about 10 to 15 seconds to get meaningful information. Because there is an asymmetry in information coming from both sides, you will have at the end of that sequence of movement an nystagmus beating to the opposite direction, toward the healthy side. Now, all of this would help us figure out what's going on in the peripheral vestibular system, but we all start by, when we see the patients, it's the symptoms that are going to guide our investigation and our management for them. And usually when they come with a plethora of descriptions for their symptoms, we try to categorize them into those four big categories: lightheadedness, disequilibrium, vertigo, which is an illusion of movement, whether it's a spinning or not, and oscillopsia, which is a subjective illusion of visual motion, which is, unlike vertigo, only present when the eyes are open. Even in the dark, somebody who has vertigo should be able to sense an illusion of movement or a sensation of movement. The Berenice Society tried to make better sense of those classifications, and in 2009, they basically came up with this very elegant algorithm where they categorized the symptoms into four broad categories. One is called internal vertigo, which is a sense of self-spinning without the environment around us spinning, that can be further divided into spontaneous or triggered. Dizziness, which is defined as a sense of spatial disorientation. Vestibular visual symptoms, and the hallmark presentation of that is external vertigo, which is the spinning we see in neuronitis, for instance, but also visual lag and movement-induced blur, which are related to those corrective saccades we see in vestibular hypofunction, for example. Oscillopsia, which can be dependent on head movement, which is also seen classically in bilateral hypofunction, or the one that occurs even without head movement when somebody has a spontaneous downbeat nystagmus, where they cannot keep their eyes, the image on the retina. And finally, visual tilt, which is a hallmark otolytic presentation, usually due to a visual illusion and a mismatch between what your eyes are saying and what the utricle and saccule are sensing the vertical is. And finally, postural symptoms, which are further defined into unsteadiness, near falls or falls, but also directional pulsion, which is another word for drop attacks. And while directional pulsion and drop attacks can be seen in brainstem infarcts, we know that in our field, we see them mostly in the setting of Meniere's disease. So according to the third law of Ewald, once the crystals fall into the posterior semicircular canal, when you put the body and the head in the triggering position, there's a flow of endolymph away from the ampulla that would lead to a significant stimulation, leading to an upbeat torsional geotropic nystagmus. And then when you sit back up, there should be a reversal of the nystagmus to a downbeat, opposite beating nystagmus. We also see atypical BPPV that like the superior canal BPPV, and here just focus on the left eye, where there will be a downbeat torsional geotropic nystagmus when you lay the patient back in the Dix-Hallpike position. And the dorsal component in superior canal is sometimes difficult to see. And finally, horizontal canal, which is a purely horizontal nystagmus when you do a supine roll test, which is not a complete extension of the neck. You go back about 30 degrees, and you can see a right beating horizontal nystagmus on the right side that switches to a left beat horizontal nystagmus when you turn the patient's head to the left. And we also know that there are cases of BPPV where the crystals or the otoliths are stuck on the cupula and can cause a more intense symptomatology and an unusual apogeotropic beating nystagmus. But what about cases where you have positional vertigo that we see often in clinic, and you cannot attribute this to the typical benign paroxysmal positional vertigo? This is a case study of a 51-year-old who presented with episodic vertigo for the past 8 years. She had a previous diagnosis of BPPV, treated with Epley multiple times. She had an episode of vertigo in December 2020 following vaccination. And of note, any type of inflammatory process could trigger this kind of the BPPV. About 40% of patients with BPPV can say that in the past few weeks they've had an upper respiratory infection or something of the sort. And the current episode I was seeing her for was dragging on for 6 months. It started after a bike ride in April 2021, settled down a bit, then came back in July 2021 after a car ride. And she would describe a spinning sensation when she rolls to the right side of her bed that would last minutes at a time. And she had had many Epley maneuvers done. And ironically, she was also a vestibular audiologist. She presented with a fullness in the ear, and an outside audiogram showed a low frequency hearing loss. When we repeated it, there was this small air-bone gap. Tympanograms were otherwise normal. And in addition to her positional symptoms, she was describing feeling off balance for the past few months, sometimes noting a rocking sensation. She would feel better when she's moving. She feels that she keeps on moving even when she stops, like on a traffic light. She didn't have migraine headaches or light or sound sensitivity. She didn't have tinnitus. She did have only a history of migraine headaches that were not active. And an outside VNG that she came with also showed a very small right beating nystagmus spontaneously that was slightly worse in the Dix-Hallpike on the right side. And that's how her exam looked when we leaned her on the right side. She had an initial upbeat torsional nystagmus for 2 beats, followed by a slower amplitude right beating horizontal nystagmus that continued, that didn't stop throughout the positional testing. So this kind of brings up the question of heavy and light cupula, which are, theoretical concepts, but are grounded in our knowledge of what's happening in the peripheral vestibular system and all the knowledge we acquired from the BPPV literature. There's a subset of patients who have horizontal geotropic nystagmus that persists and does not fit with typical BPPV. And we think it is related to the deviation of the cupula due to density changes. Some statistics consider it to be responsible for 5% of misdiagnosed horizontal BPPV, and 14% of patients with direction changing nystagmus could have something other than horizontal canal BPPV. And this is not a new theme. We've known for a long time that positional alcoholic nystagmus causes something similar. We know that in the early phases of alcoholic inhibition, the alcohol goes into the cupula and makes the cupula less dense than the surrounding endolymph, and you have a geotropic horizontal beating nystagmus. And then the nystagmus goes away when the density equalizes across the cupula. And then when all the alcohol has basically diffused out of the cupula, you will have a sinking of the cupula because it becomes heavier than surrounding endolymph, and you get an apogeotropic nystagmus. So one of the postulated mechanisms is that something is making the cupula lighter, or something is making the endolymph heavier, whether it is a labyrinthine bleeding, an ischemic lesion of the ear, an inflammation from surrounding CNS structures. And interestingly, many studies with sudden sensorineural hearing loss presenting with vertigo also describe that patients would have this unusual positional nystagmus. And another hypothesis describes potentially debris that are stuck on the cupula, and instead of making it heavier, they make it more buoyant. And some of the candidate debris include inflammatory cells in the endolymph or chemically generated products from the otoliths that had fallen. The otoliths are a calcium carbonate core within a matrix that contains many proteins. And once they fall into the endolymph, there's a whole system that is designed to break them down and resorb them. And when that system is not working, you could have a megalith, but you could also have those free-floating degeneration products that could end up getting stuck on the cupula. Two additional mechanisms were postulated, including the utricular macula. Even though it can explain the sensation, it cannot explain the nystagmus, and a density mismatch between perilymph and endolymph that would subject the membranous duct to a more floating force, and then, because it's deformable, can deform the cupula housed within it. We cannot talk about light cupula or any vestibular talk, quite honestly, without bringing up vestibular migraine. Positional nystagmus has been long known to be associated with migraine. Even in the 1960s, when Asher was describing the types of positional nystagmus, there was type 1, the typical BPPV, type 3, the typical vertical positional nystagmus that is of a central pathology, and type 2 was listed as a migraine positional nystagmus. And conceptually, how could migraine cause that? Well, migraine is there's something happening at the level of the vestibular nuclei in the central processing of influx of information from the vestibular system that causes an interaction with the trigeminal nociceptive pathways, which we know for a fact that the inner ear's vasculature is heavily innervated by the trigeminal nerve branches. And that could lead to changes in inner ear metabolism that could lead to light cupula. But similarly, a problem in the inner ear, like BPPV or sudden sensorineural hearing loss, can cause an abnormal function of the inner ear, leads to a central processing that would lead to exactly the same symptoms. Other CNS disorders like a brainstem stroke or a cerebellar tumor or even certain types of encephalopathy have been implicated with the light cupula mechanism. And with the advent of the MRI delayed sequence that detects high drops, we found that things like retrocochlear tumors, like schwannomas, can be associated with high drops. So it's not a stretch to think that a retrocochlear pathology could also influence the endolymph homeostasis physiology. So given all of this and her resistance to all types of maneuvers that were treated before she came in, we decided to put her on a sodium channel blocker, and we ordered an MRI to rule out weird, unusual things. And 6 weeks later, she presented with complete remission of her symptoms, and her nystagmus was gone as well. And she had an MRI that showed a retrocochlear small schwannoma in the same side IAC, which could be related to what we were seeing as well. And she's now 3 years out and still in remission and still refusing to come off that medication. So the pearl of this case, which we encounter actually pretty frequently, similar cases, is to always look for a pseudo BPPV and look for other pathologies when patients have had a decent course of vestibular therapy and they're not responding, and make sure that the therapist has really tried all the maneuvers that are present in their armamentarium. Now, in addition, we talked about how this interaction between peripheral and central can sometimes muddy the waters, and how a central process can present like a peripheral pathology. We have to remember that the membranous labyrinth is also a metabolically active organ within the ear, especially at the level of the endolymphatic sac, which is very immunologically active and a site of crossing of all the inflammatory mediators coming from the systemic part. And we know that this small area that contains less than 1 cc of fluid has a lot of ion channels, a lot of receptors for steroids or other medications. And we've shifted our thinking about Meniere's disease over the past few decades from this being a hydrops, or from the hydrops being the main cause, to the hydrops being a kind of a end product of upstream mechanisms that would lead to a hydrops developing. This group from Europe has done a great job about describing clusters of phenotypes of Meniere's disease. The classic phenotype 1, which is the idiopathic one we usually encounter, is the most frequent one and is associated or believed to be related to a dysfunction or a deregulation of sodium metabolism within the ear. Type 2 is a delayed Meniere's disease hydrops, which is related either to an injury to the ear, like a sudden sensorineural hearing loss, followed a decade later by a Meniere's disease presentation, or a post-surgical manifestation. Type 3, which is familial, and some cross-linkage analyses have found certain genetic mutations associated with sodium channel metabolism and aquaporin receptor metabolism. Type 4 associated with migraine, and we're not talking about vestibular migraine or about migraine presenting with the episodes. This is a subset of patients with Meniere's who also have a migraine pathology. And type 5, having autoimmune disorders associated with Meniere's disease. And many studies have been done to look at the inflammatory signature in both Meniere's disease and migraine. And certain mediators or cytokines come up. So there's a thinking that the Meniere's disease can be divided into two groups from a basic science standpoint, if I may say. One that has high levels of IL-1 beta and one that has low levels of IL-1 beta, with vestibular migraine patients presenting with similar inflammatory signatures as that of the Meniere's patients with low levels of IL-1 beta. And that raises the possibility that Meniere's disease is an autoinflammatory condition with higher circulating levels of pro-inflammatory cytokines. And autoinflammatory conditions are things like migraine, like asthma, like periodic fever. This is the type of pathologies that can be listed under an autoinflammatory condition. Dr. Van Budas and her group also published a lot on immune-mediated inner ear disease, which sometimes includes Meniere's patients. I mean, it's sometimes very hard to differentiate an AIED with vertigo from Meniere's disease. And they found this high expression of IL-1 beta, which we know can trigger downstream effects on TNF alpha and IL-6 and CCL3, which are other mediators implicated in this response. We kind of are building up on that line of research, and in our study that is yet to be published, we have already seen that there's an elevated levels of TNF alpha and interferon gamma levels, and a reduction of ENA 78, which is a mediator specifically related to the eosinophilic pathway, which kind of brings us back to the allergy and eosinophilic pathways that are implicated in Meniere's disease. And TNF alpha is also typically elevated in autoimmune inner ear disease. So that also shows us how much there's an interaction with that small part of the body, this peripheral vestibular system, and the entire systemic inflammatory response. We cannot talk about Meniere's disease without mentioning the Tumarkin crises or the drop attacks. And I encourage everybody to read the first description of it in this 1936 case report by Dr. Tumarkin, the British physician who described it, because the way he describes the clinical presentation kind of gets seared in your mind, and you will know how to ask your patients when they are saying that they're having a drop attack, and you kind of figure out and differentiate this from a vagal reaction. And the drop attack is usually related to a sudden shift of the utricular macula or a pressure change within the utricle that can lead to a complete loss of tone in the truncal muscles that can lead to a fall if it happens at the level of the utricle, or to a lateral pulsion, like a sense of being shoved to the side when it's in the sacula. And while it is usually ascribed to a Meniere's disease, there are other situations where it can happen. For example, in this case, it was following an Epley maneuver done by Gary Jacobson, and he recorded it in his textbook, where that lady, after being repositioned, had a sudden onset of a fall, was being shoved to the side. And the mechanism implicated in this is uh, the sudden return of the crystals of the otoliths into the vestibule can create a sudden change of pressure within the utricular and saccular macula that can lead to that. Now, we certainly have to differentiate when a patient reports a drop attack from a vasovagal reaction or something called vestibular syncope. And we all have those patients when we ask them about how their symptoms are, and they say, well, I feel like I'm going to pass out. I've had patients in the middle of a Dix-Hallpike where the nystagmus is going like 20 degrees per second, and I ask them, are you feeling any spinning? And they say, no, I feel like I'm going to pass out. And it's not the patients being vague or unclear. The vestibular system has a lot of connections with the autonomic nuclei and can affect cardiovascular homeostasis so fast that it's much faster than the baroreceptor reflex. The vestibular syncope has been reported in up to 4% of patients during a Meniere's episode. It's been reported with BPPV and with 3PD as a secondary diagnosis. There are certainly risk factors. Older patients on antihypertensive or with cardiac or renal disorders are more likely to describe that. And the way we think it works, or has been postulated to work, is the vestibular sympathetic reflex is triggered by changes of orthostatism. Like if you go from a sitting to a standing position, that would trigger your vestibular system to raise the sympathetic tone, which will lead to a higher heart rate and increased blood pressure. And when you're actually changing position, this is followed by a shift of the body fluid downward, which will trigger the baroreflex receptor in the usual fashion. By sensing a drop of the pressure, it will cause an increase of sympathetic tone, and you will have the blood pressure maintaining itself. However, when it happens in the setting of a vertigo attack, where there is a perception from the vestibular system that you actually moved up, it creates the same sense of gravity downward vector. You will engage your vestibular sympathetic reflex. You will have a high heart rate, increased pressure. But unlike in the first scenario where there's a displacement of fluids downward that will trigger the baroreceptor reflex in the right direction, in this case, there's no downward shift of fluid. The baroreceptor reflex will detect an increase of sympathetic tone and will engage the parasympathetic tone, and you develop a vasovagal attack, which can lead to a syncope in certain cases. And all of those physiological, and pathophysiological observations rely on the fact that we are living in a gravity-bound world. And none of this would supposedly work if we are in microgravity. From the early space flights where they did experiments, we found that most of the caloric response is blunted when you are in space. We also find from studies on astronauts that the vestibular ocular reflex is disturbed with a reduction of this velocity storage system for two reasons. First of all, there's a change in the density displacement of the cupula, but there's actual change in longer stays in space and velocity storage in the cerebellum part that stores that response. A lot of astronauts describe oscillopsia upon reentry that can last hours to days. And when you think about being in a gravity-bound environment your entire life, you can certainly understand that when this gravity vector is taken away in a sudden fashion, like when you're doing a spacewalk, there will be changes that the system has to adapt to rather quickly. This is a description from an astronaut about his first spacewalk.
think there's a problem with the sound of the video.
Oh, well, basically what he's saying is when he did his first spacewalk, as soon as he became far enough that he couldn't no longer accommodate the space station in his visual field, he felt a sensation of free falling like 100 miles an hour in a parachute. And what he was describing is that in weightlessness, the otolith organ, we know the semicircular canals are not working well, and the otolith organs are only part of the vestibular system that is giving us appropriate information. However, in weightlessness, the otolith organs can no longer detect the head tilt from the vertical. So they only rely on acceleration. As we said, the utricle and saccule detect tilt and acceleration stimulus. And in weightlessness, they only act like accelerometers. So when astronauts return home, they experience after effect from the otolith organ disruption, difficulty walking around corners, sensation of linear movement or free fall when they tilt their head. Vestibular neuronitis can cause similar symptoms if you listen attentively to the patients describing their first few days of symptoms. Vestibular migraine can cause similar symptoms. Space motion sickness, visual reorientation illusions, are due to a conflict between what the utricular and sacula are sensing and the other senses. If anyone has seen the Apollo 11 movie when they had the failures of their instruments and they had to navigate by vision alone and how dangerous that situation was, it's because if they without the vision and if their otolytic organs can give them wrong sensory information and they can end up in the wrong side up basically. And this is what the danger of being in weightlessness and not having instrument navigation. Now, this what is even more interesting is that in weightlessness, there is also anatomical changes that occur. There's a lot of studies that were done on the optic nerve atrophy that happens in astronauts when they return after a long stay in space. But animal studies have shown that the vestibular end organs can be dramatically altered in weightlessness, with increased density of peripheral nerve connections to hair cells to making them more sensitive, and especially at the level of the otolytic organs. And all of the otolith disruptions can cause a sensation of floating and weightlessness that we also observe in our vestibular migraine patients. I'd like to it's kind of a personal musing of mine that as if my vestibular migraine patients are a model of what would happen in weightlessness, but when we are in a gravity bound world. And this builds up to the second part of the talk where I wanted to kind of review how richly plugged in the vestibular system is to the vast network in our brain of many other systems and functions, and to talk about how do we compensate from a peripheral vestibular injury. We all know, I mean, this slide offers nothing new, how central the central vestibular nuclei are and how many afferences they get from many parts of the brain upstream, but also downstream from the spine, from the inner ear, and from the oculomotor nuclei. The cerebellum plays a major role in motor coordination, motor learning, and adaptation. And in animal studies, we know that there is something called the PIVC or the vestibular cortex, PIVC standing for parieto-insular vestibular cortex. In humans, while it hasn't been mapped as diligently as in animal studies, we know there's a similar structure that exists that is widespread and disseminated in the insula, very close to the auditory cortex, olfactory cortex, and parietal cortex. And the thought is that this wide dissemination of the vestibular signals in the cortex is potentially an evolutionary process with sparse coding that allows us to rapidly learn, to have a large storage capacity, and has a high tolerance to degradation. So from the vestibular nuclei, upstream, we have the vestibulothalamic and vestibulocortical pathways that are responsible for motion perception and space orientation. The downstream vestibulospinal pathways that have motor commands to the muscles of the neck and upper torso and maintain us upright and allow us to stay upright. And the vestibular ocular pathways that we are most familiar with and are responsible for the VOR, but also the higher order strategies of smooth pursuits and tracking. And what's even more fascinating is there are really specialized cells that are basically decoding at every second of our motion in space where we are in space and where we are according to the environment that we're scanning continuously, and a sensation of self versus outside of the self. And it's not a surprise that the vestibular system has been implicated in a number of processes, including number processing, spatial cognition, and theory of mind, which is basically the concept that the beliefs and behaviors of others can be attributed to their mental state. And because we have that sense of myself versus the outside environment. And all of this rich network that we are talking about made me ask the question if our clinical approach to the vestibular system compartmentalization adequate. And this is a wonderful paper from Brandt and the Munich Dizziness Center group that describes how much there's an overlap between peripheral and central pathologies that cannot just be brushed away based on anatomical lesions or locations, because there's a lot of overlap in the clinical presentations. And you can have a peripheral lesion that can engage the entire spectrum of those pathways we talked about, affecting the cortex, which would lead to spatial disorientation and wrong perception of motion, affecting the brainstem and leading to nystagmus, the spinal pathways leading to gait and ataxia, and the autonomic system leading to nausea. And going over a few examples of this, like a central lesion that can mimic a peripheral disorder, you will see sometimes patients coming with a diagnosis of MS that is inactive and they are dizzy. I always pay attention that if they had an MRI, that there is a fine cuts of the MRI around the IAC. I've had a few cases of patients who presented with a neuronitis picture and they had a known MS, but the MRI did not show a plaque. But when you repeat the MRI, there was a plaque on the root entry zone that was active. What also is interesting is some MS patients can present with asymmetric hearing loss in the mid frequencies that mimics Meniere's disease. And you need to be careful not to ascribe it to a Meniere's disease because it could be a plaque. Another pathology that can be mimicked with MS is vestibular paroxysmia, where you will have short-lived attacks that are not triggered by positional changes. And I always get an MRI, partly because it is part of the diagnostic considerations to rule everything out, but there have been a few cases of MS presenting like that. And the current thought of vestibular paroxysmia, especially when there's no vascular loop pressing on the vestibular nerve, is that there could be a focal demyelination of the nerve, whether it's MS or something else that we cannot detect with our current MRI technology. So always also do a head impulse test, because if you have something that feels like peripheral, but the head impulse test is normal, then you should think again, and maybe you're missing a central process. And we know that peripheral lesions usually cause more intense symptoms because they're engaging the entire spectrum of those upstream pathways. Central lesions usually give more single components, such as a vertical tilt sensation when the utricular pathways are affected, for instance. So we can suggest a different way to classify the disorders we're seeing. Instead of talking about peripheral and central, we should probably look at pathophysiological classification. Is it a bilateral loss? Is it an acute loss? Is it a paroxysmal loss? And even more interestingly, can we attribute the symptoms and what we're seeing to a semicircular canal disruption or to an otolytic disruption, regardless of whether it is peripheral or central? And from there, we can talk about how do you recover from a damage to the end organ, the peripheral vestibular system. Well, the first case is in case of a unilateral deafferentation. This is a personal case because that's me, and that's a few years ago when I had a neuronitis. And I'm going to walk you through the symptoms I had. The first day, I felt spinning when I would lay on my left side. That would get better when I laid flat. I thought I was having BPPV. It's only by day 5 that vertigo became constant, even when looking straight ahead. And I developed the typical symptoms with a left beating nystagmus in all directions of gaze, even when I was looking toward the right side, the affected side. In unilateral vestibular lesion, there's a spontaneous nystagmus with the fast phase toward the healthy ear that can even be stronger when you're looking toward the healthy ear, which is the way of the brain to make sense of that asymmetry. The brain is thinking you're moving toward that healthy ear and wants the eyes to move faster towards it. And this is what my head impulse test looked on the first day of the bad vertigo, where the gain was starting to go down. I was still at 77%, so normal by the current, 80 is usually the cutoff, and a beginning of saccades that are starting to occur. The nerve was not completely degenerative at that point. After 5 days of bad vertigo, it started to subside, and I started noticing more utricular symptoms, a sense of free falling whenever I tried to tilt my head to the right or left, because the utricle was no longer detecting my tilt away from the vertical. And this is how the head impulse test looked at that time, with a gain down to 20% and a completely asynchronous saccades. And the recovery happened slowly. Initially, the vertigo went away, and then balance was off for a few days. You can start to see how the saccades were being lumped because the brain is starting to predict where the eyes need to land with the head movement. But then there was a dip, and that dip, I always, when I give that talk and give that case, I talk about that because that dip happened. I had a newborn and I wasn't having much sleep, and I felt a worsening of symptoms. And we went to the lab and got the head impulse testing. And that taught me also, whenever I have a patient who has trouble compensating, to always screen them for sleep apnea or other sleep disorders. And often you will find that there's something going on from the sleep standpoint. So the recovery took some time to get back to, at month 8, what looked like almost a normal head impulse test, which a lot of our patients present like that. They've had an injury several weeks or months ago, and you do a head impulse test when they come in, and you barely see anything abnormal, hence the importance of the history, obviously. But in this case, there's this scar that I will be basically carrying for subsequent head impulse tests that will show that something happened in that ear. Does the same, would that happen also if you had a bilateral deafferentation? And the answer would depend on how did you develop that injury to both inner ears. When it's happening in a sequential manner, then yes, Bechtereau had described this in animal models, but then David Z published a case report about somebody having a similar situation, where basically if you have a labyrinthectomy or a nerve section that you recover fully from, and then you have an injury on the opposing side, you would think that you shouldn't have any nystagmus at that time because there was no functioning labyrinth on the other side. But this is how fascinating the recovery process at the level of the vestibular nuclei is. And patients who had a second side sequential injury will have an nystagmus beating away from that side toward the other side, which is not healthy, which is already destroyed. The things are different and stakes are different when it's a concomitant deafferentation, which we see in ototoxicity, but most frequently we see it in an idiopathic manner. Those are young 30, 40-year-olds who come with oscillopsia, and you discover a bilateral hypofunction. I'm sure a lot of people are familiar with this article, which is actually a book chapter where this physician had bilateral hypofunction triggered by streptomycin. And he describes his journey of compensation, how he was able to reduce his symptoms. And he kind of finishes on this sentence that I find pretty impactful. Is there any man-made machine designed like the human apparatus with so many alternate systems to accomplish its end? And obviously, patients with bilateral hypofunction have a significant detriment to their quality of life. And there's very little we can offer them other than physical therapy at this time. However, hopefully in the future, this will change. And there's currently a lot of work being done to develop the vestibular implants. A lot of progress has been made as well. There's 4 groups simultaneously working on this and developing various forms of vestibular implants, which would be beyond the scope of this talk. What is also interesting is there's also studies being done on galvanic stimulation of the vestibular system that is meant to modulate the functioning of the peripheral vestibular system and hopefully impact central and upstream pathways as well. And this also leads us to a second question: can the peripheral end organ affect higher cortical functions, which we've been seeing already that it does. And the vestibular network integrates with in cognitive functions in the cortex and in the hippocampus and limbic system, which helps us get an internal representation of our body, of our surrounding space, and a multisensory perception of what we're doing in motion, in addition to spatial memory and navigation. So higher vestibular function can be affected by a lesion of the vestibular cortex or even in the peripheral end organ. And disorders of higher vestibular function can affect other sensory modalities. And sometimes cognitive dysfunction could be the only higher function disrupted by a peripheral end organ. And these are the patients you see who've had a neuronitis and they've recovered and they tell you, I don't feel dizzy. I have a brain fog. I just don't feel, I feel spacey. And you can no longer attribute the peripheral injury you're seeing on the calorics that was fully compensated to their symptoms immediately, except that it could that the peripheral end organ injury has affected the upstream pathways. And there's three examples that we see in the neurology literature uh, that examine this concept. The one we're most familiar with is the bilateral vestibular loss patients, whether it's a bilateral hypofunction or in NF2 cases with spatial memory deficits and hippocampal atrophy. But there's also two other disorders like the spatial neglect disorders, which are usually due to strokes or lesions in the parietal lobe, close to where the vestibular cortex is thought to be in the human brain in the non-dominant hemisphere. And there's a question whether the spatial neglect is not actually a type of multisensory vestibular cortex disorder. And the room tilt illusion with transient upside down inversion of vision, which is traditionally attributed to lower brainstem infarction or vestibular epilepsy. But recent studies have shown that it has been described in some Meniere's disease patients or bilateral vestibular deficit patients. I've also seen it happen once after a labyrinthine plug for a canal dehiscence, where the patient in the recovery room has described a complete inversion of their visual environment that's eventually settled down, thought to be to an injury or an inflammation to the utricle after plugging the labyrinth. I've also had a couple of Air Force pilots who are usually very resilient to cross-modal illusions because when they fly upside down, they are trained to actually overcome that sensory misperception, who presented with episodic visual tilt illusion. And that would come out of nowhere, resolves in a few seconds, and had extensive workup between EEGs and MRIs. And the only consistent thing with those two specific patients was an abnormal ovamp on one specific side, potentially attributed to a utricular dysfunction that is causing that mismatch between the visual and the vestibular vertical. And when we look at the aging of the vestibular system, we have a better understanding of how those higher vestibular functions can be impactful. There's a lot of studies that show the marked age-related degeneration of the peripheral end organ, starting at the age of 65, affecting mostly the saccule. And while earlier studies couldn't correlate it with caloric and rotary chair testing, with the VEMP and the VHIT, we have a better window about the functioning of those structures, and more evidence is coming to highlight the prevalence of those abnormalities. It's no secret that dizziness increases with age, and about 50% of those patients may have peripheral vestibular disease as a cause of their dizziness and imbalance. And a staggering 85% of individuals over 80 have evidence of balance dysfunction, which led the Berenice Society to define the criteria for presbyvestibulopathy as a chronic vestibular syndrome with mild findings of weaknesses on paraclinical testing in individuals above the age of 60. And again, presbyvestibulopathy is at the intersection of other abnormalities, whether it's affecting the proprioception component of our balance or the visual component of our balance. And basically, with the presence of presbyvestibulopathy, those patients are at a higher risk of injury and falls. And why is that important? This cover of the National Geographic was published in 2018, And apart from that diversity picture, which is obviously untrue because of how much health disparities there is, I doubt that those 4 babies will have the same life expectancy. We're saying that a child born today may live to be up to 120, which means about a third of their life would be spent with significantly reduced vestibular function. And that's something we need to be thinking of as we continue to kind of increase our knowledge in that field. And because of all of those studies about aging, the question about cognition always comes back. And a plethora of articles have shown over the years the connection between peripheral injury and concentration difficulties and memory impairments. Yuri Agrawal published about many papers, but 3 of those papers show reduced vestibular function is associated with poor cognitive performance. And hippocampal atrophy is no longer just seen in bilateral hypofunction. It's been also described in Meniere's disease. Learning disabilities in children can sometimes be attributed to vestibular disorders. And there's a lot of effort being done here in the US, but also in Europe, about studying those dyscalculia, dyslexia patients and figuring out how much of those patients actually have undiagnosed peripheral vestibular disorders. Alzheimer's disease patients are twice as likely to have vestibular impairment than healthy controls. I think this was a fascinating study that showed that Alzheimer's disease patients have a disproportionate reduction in spatial cognition compared to those to their counterparts that didn't have vestibular loss. And it even offered postulated a mechanism where the peripheral vestibular system is affecting the cholinergic neurons in the medial temporal region, which is specifically degraded in Alzheimer's disease, and suggesting a potential mechanism where vestibular impairment can lead to a specific phenotype of Alzheimer's where there's a higher risk of spatial disorientation. And can we quantify cognitive impairment in vestibular patients? Most of them don't have the level of memory impairment when you see them in clinic that would make you think, oh my God, this is a dementia starting. But they describe this feeling of brain fog, this depersonalization sensation, the sensation of being spacey. And we've sought to quantify this by using the cognitive failure questionnaire, which was used over the years in occupational medicine to check if return to duty for pilots and nurses, are they able to return to duty? Are they having a lot of errors in their daily activities? And we found that in disorders like Meniere's disease, vestibular migraine, and 3PD, despite being 1 or 2 decades younger than their counterparts with benign positional vertigo, those patients scored higher on the cognitive failure questionnaire. We also looked at the neuropsychological vertigo inventory that was developed by a Belgian psychologist, Emily Lacroix. And we showed also that in our disorders, the most frequent ones we see, Meniere's disease and migraine, we have a higher incidence of a higher level of dysfunction on the NVI score that is not attributed to age, which I think I'm running low on time. So I'm going to just kind of go over this last part of the talk pretty quickly. And I entitled it Vestibular System and Self-Perception. We know that the vestibular system has a significant impact on our ability to work. It also has a significant impact on healthcare utilization, with a staggering direct costs in billions of $150 billion for episodic vestibular disorders, including BPPV, Meniere's disease, and vestibular migraine, more than arthritis and migraine headaches combined. And in addition to the sense of self-worth that comes from actually being able to work, we've shown how much there is interactions between the peripheral vestibular system and the higher executive functions. And the vestibular system is responsible for our perception of our environment. And the perception of our environment is a typical multisensory process. And it seems like the vestibular system is one of those senses that is the glue between the other senses. We know that a dysfunction in one of the senses can influence the other ones, which can lead to cross-modal illusions. And it's because of our perception of the environment that we can develop cognition and form beliefs and make decisions. And regardless of other esoteric, considerations, the vestibular system is responsible for our cognition in motion. And there's thoughts that it can lead to personality changes and a change of our self-perception. not only related to how the limbic system is affected, but also to the fact that the vestibular system can influence the other senses, like we discussed. So those studies were done way before PPPD was even a diagnosis. It was since the 1980s that this high rate of depersonalization symptoms were described in vestibular patients, feeling as walking on shifting grounds, feeling spacey, thoughts seeming blurred. And they're much higher in people with bilateral weaknesses compared to people with unilateral weaknesses. And again, a plethora of studies have shown how the vestibular sensation contribute to the definition of self and how dysfunction can promote feelings of disembodiment. An actual inactivation of the labyrinth using intratympanic tetrodotoxin or a surgical labyrinthectomy can result in loss of firing of the hippocampal place cells, which are responsible for our grounding us in the space we're currently in. Stimulation of the vestibular system can activate the temporoparietal junction and lead to out-of-body experiences. And to conclude, basically what's going on when we are actually in motion, the brain is constantly trying to estimate all the current sensory information coming its way, and it's trying to predict outcomes. And there's what we call control policies that affect how we act given the current state of the body to attain a motor goal or a movement goal. And when you have a vestibular dysfunction, the state estimation is getting the wrong information. And this is why repeated vestibular rehab is helpful, because it helps the state estimator adjust its predictions and eventually leads to compensation, such as the perfect example, how the saccades begin to synchronize and begin to be very predictable. And so it also explains why vestibular therapists always tell our patients the inner ear likes movement, because it's only in movement that you can perceive motion and you can adjust your inferences and know where you're heading and the amplitude of your stance. And while in the normal human being, we coordinate our multisensory perception from the bottom up, where the vestibular system is so quick that it provides us quick info for quick decision making. In pathological state, the compensation that happens, especially with vestibular rehab, helps us adopt a top-down approach where we are using other systems to predict our upcoming motion. And the vestibular system is kind of becoming a bystander in this situation. And in conclusion, I mean, I hope I had imparted why I feel as otologists and otolaryngologists, we have an intimate place at the center of those pathologies in collaboration with a team, because this is such a complex mechanism and system that we should be a big part of, but we also have to be collaborating with the multitude of disciplines that can have an impact on those patients. Thank you for listening. Feel free to email me or send me a message if you need to discuss something. I'm available on my phone. And I wanted to do a final plug-in for the ANS VIDA grant that's going to go live next year. So be watchful for the announcements on both the ANS and VIDA websites. Another plug-in for the HEADS registry that was developed by the Association of Migraine Disorders. Try to send your patients to that registry. It will increase our knowledge of how migraine can impact our patients with ear, nose, throat symptoms. And consider the Migraine and Otolaryngology Society. It's a free membership with a lot of resources if you need to have any questions or discuss any cases. Thank you.